Well, hello, everybody, and welcome to the NJX Special Population Webinar Series. I'm Steve Crystal. It's my great pleasure to introduce Qiana Brown, who is I do have to add, an NJX member as a KL2 fellow, and Dr. Brown is an epidemiologist, social worker, translational scientist, and assistant professor at Rutgers School of Social Work and School of Public Health, Department of Urban and Global Public Health. She directs the Sure Match Group at the School of Social Work Center for Prevention Science. From a health equity lens, her research focuses on system-level change to improve maternal and child health, centering on preventing prenatal substance use. Dr. Brown's peer-reviewed research has been published in top-tier journals, including JAMA. Dr. Brown has received national and international honors for her research, including being named a Woman of Future Influence in Addiction Science, being elected to the board of directors for the College on Problems of Drug Dependence, the longest standing professional organization in the United States focused on substance use disorders. He's also a member of the board of directors for the New Jersey Association of Women in Science and a member of the Governor's STEM Scholars Advisory Council. Prior to joining Rutgers, Dr. Brown earned her PhD in mental health and drug dependence epidemiology from Johns Hopkins and completed a postdoc in substance abuse epidemiology at Columbia University. She's working in the intersection of some of the most important areas in public health today, and it's my pleasure to turn it over to Dr. Brown.
Thank you so much, Dr. Krista, for that wonderful introduction. I am very excited to be here. I'm just going to share my screen now so you can see my slides. And today I am going to present research that's part of my KL2 Career Development Award focused on prenatal cannabis use. And I'm going to talk specifically about the relationship between perceived risk of cannabis use and prenatal cannabis use amongst women in the United States. I like to start by acknowledging my collaborators in this work, to include Dr. Crystal, who is my primary mentor on my Career Development Award, as well as the lead for the NJX Special Populations Core that's hosting me today. I would like to acknowledge my other collaborators from Rutgers University, Columbia University, the University of Cincinnati, UCSF, and Kaiser. And I would like to especially thank the NJX for funding my Career Development Award in support of this research. So, the $1 million question with regard to prenatal cannabis use is whether or not it's harmful to maternal and child health. Evidence is still emerging in this area of research, but according to the current state of science, prenatal cannabis use is associated with poor maternal and child health outcomes across human and animal studies. These outcomes include maternal anemia, low birth weight, and neurodevelopmental deficits in offspring. Based on this research, the Surgeon General's Office, the American College of Obstetricians and Gynecologists, and the American Academy of Pediatrics recommend that women abstain from cannabis use during preconception, pregnancy, and lactation, and that physicians and healthcare providers counsel and screen women on the health risks associated with prenatal cannabis use. However, these recommendations are being made within a social political backdrop where the majority of states in the US have legalized cannabis for medical or recreational purposes. 33 states in DC have legalized cannabis for medical use. 11 states in DC have legalized cannabis for recreational use. And according to a recent Gallup poll, the majority of Americans believe that cannabis should be legalized. So there's no surprise that perceived risk of cannabis use has decreased among pregnant and non-pregnant reproductive age women in this country. And this is what we see in the bottom figure. This figure reports the predicted probability of reporting no risk of regular cannabis use amongst pregnant and non-pregnant reproductive age women in the United States from 2005 to 2015. And we see that this trend, there's a significantly increasing trend of women reporting that cannabis use during pregnancy is essentially safe. My research is going to examine whether or not these risk perceptions are actually related to prenatal cannabis use. However, we need to put the examination of individual correlates of prenatal cannabis use, such as perceived risk, into the context of the larger social environment, to include those macro level factors such as cannabis use legalization that might contribute to decreased risk perceptions of prenatal cannabis use and ultimately lead to cannabis use during pregnancy. And I describe a potential pathway to help us to understand both the individual and macro level factors potentially influencing prenatal cannabis use in an editorial that I published in Addiction entitled Possible Unattended Consequences for Pregnant Women of Cannabis Use Legalization. And I expand on this conceptual model by discussing strategies to promote health and social equity for women who use cannabis during preconception, pregnancy, and lactation in light of legalization, cannabis use legalization in this country. As researchers, practitioners, and policymakers, we often focus on the right-hand side of this model when we're addressing prenatal cannabis use, because the obvious thing that will come up, the obvious intervention is treatment for those women who need it. Treatment, prevention, health education, as it should. Unfortunately, we also criminalize prenatal substance use in this country. No other country outside of the United States criminalizes prenatal substance use in this way. About 25 states in this country consider prenatal substance use child abuse and neglect. So physicians, social workers, and other healthcare providers are mandatory reporters. So if a woman is suspected or tested positive for substance use during pregnancy, they're required to report these women to the authorities, oftentimes social service agencies. This undermines maternal and child health and undermines treatment efforts. The ACOG, the American College of Obstetricians and Gynecologists, have been working for a decade to repeal these antiquated policies, and they encourage physicians and other healthcare providers to work with legislators to repeal these policies in favor of promoting non-punitive, evidence-based practice to treat and prevent prenatal substance use. In my study today, I want to walk you back towards the left-hand side of this model. And I want you to ask yourself this question: how can I intervene on risk perceptions of cannabis use and those macro level predictors of perceived risk in order to prevent prenatal cannabis use? Because that's the bigger point, right? The bigger point is population level prevention, particularly when it comes to prenatal substance use. And I'm going to talk only about a little piece of this puzzle in my research. But if we want to help the most people at a time, we're going to have to engage in macro level environmental strategies to prevention. So instead of reporting women for prenatal cannabis use, think about how you can act on cannabis use legalization to ensure health equity. I'm not arguing that cannabis use legalization is good or bad, but I am arguing that we as people with a stake in maternal and child health need to ensure that these policies promote health equity, that there's clear language in policies about the potential risk of prenatal cannabis use. We as people with a stake in maternal and child health need to think about regulating cannabis use dispensaries, the access and availability of these dispensaries in certain neighborhoods, because these macro level factors may ultimately influence risk perceptions and lead to prenatal cannabis use either directly or indirectly. And unfortunately, the pregnant woman bears the burden of the consequence oftentimes in prenatal cannabis use, which limits patient-provider rapport. It leads to underreporting of prenatal cannabis use. Why would I report that I'm using substances to my OB if I think you're going to report me to the authorities, if I think I'm going to lose my child because of this? We can't treat as healthcare providers problems that we don't know about. So I want you to think about why prenatal cannabis use is underreported and what's your role in that, because it's easy to think about this as a patient problem, right? So to the study, 3 research questions guided my research in this area. Question 1, does prenatal cannabis use differ by trimester? Question 2, does perceived risk of cannabis use differ by trimester? And lastly, does trimester moderate the relationship between prenatal cannabis use and perceived risk of prenatal cannabis use, or perceived risk of cannabis use? I used the National Survey on Drug Use and Health to conduct this study, data from years 2002 to 2014. I used this range of data because these are the years that had the questions that I needed. The NISDU is conducted annually, but beyond 2014, the questions just aren't there. Nevertheless, I had a sample size of over 11,000 pregnant women. And like I mentioned, the NISDU is a cross-sectional household survey sponsored by SAMHSA. It assesses substance use disorders, mental health, and other health and health-related outcomes in nationally representative samples of the non-institutionalized US population aged 12 years and older. The results of my study are weighted to reflect the US population. So of the 11,000 women representative of pregnant women in the US from 2002 to 2014, the majority of women were non-Hispanic white, 26 to 44 years old, had at least some college education, and had a family income of greater than 2 times the federal poverty threshold. There were slightly more women in the second trimester compared to the first and the third, and about 4% of women used cannabis in the past month during this period. So in my first research question, I examined the relationship between prenatal cannabis use and trimester amongst women who use cannabis in the past month. I hypothesized that there would be a negative relationship between trimester and prenatal cannabis use. So as pregnancy progresses, I hypothesized that prenatal cannabis use would decrease. And essentially, this is what we see. In the first trimester, among women who use cannabis in the past month, the majority of women, nearly 54%, used in the first trimester. There was a sharp decrease to 31% in the second trimester, and about 15% of women use cannabis in the third trimester. Based on this trend, I hypothesized that perceived risk might be driving this. I hypothesized that perceived risk may also differ by trimester, such that women would believe cannabis use is safer in the first trimester relative to later trimesters, given that prenatal cannabis use, the prevalence of prenatal cannabis use is highest in the first trimester. And from previous research, we see that there's a relationship between perceived risk and cannabis use, specifically an inverse relationship, not only cannabis use, but drug use, substance use in general. As risk perceptions of that substance goes up, that use of that substance goes down. That's seemingly not the case for prenatal cannabis use. I did not find evidence to support this hypothesis. I found the exact opposite, actually. In the third trimester, when cannabis use is lowest, perceived risk, the percentage of pregnant women who perceive cannabis use is safe or who perceive no risk in cannabis use is highest. So what this means is that, and we see this if we follow the trend in the blue line on the graph. In the third trimester, 63% of women who used cannabis in the past month reported that there was no risk of using cannabis use monthly. What this means is, when we take a look at the orange line, is that women are using cannabis early in pregnancy, although they perceive the risk of cannabis use to be greatest earlier in pregnancy. And we can see that more clearly here. In the first and second trimester, the prevalence of cannabis use during pregnancy is highest. That's the left side of this graph. And the prevalence of perceiving slight to great risk of cannabis use is also highest here. This is a problem. Further research is needed to understand why women might be using cannabis earlier in pregnancy despite perceiving the greatest risk of cannabis use during that time. So in a unified model, in a logistic regression model controlling for confounders, I examined the relationship between perceived risk and prenatal cannabis use amongst all pregnant women. Here, these proportions are amongst women who use cannabis in the past month. In the unified control logistic regression model, I used the entire sample size, over 11,000 pregnant women. I examined the relationship between perceived risk and cannabis use in the past month. And I tested whether or not that relationship differed by trimester. As I hypothesized, trimester did significantly moderate the relationship between perceived risk of cannabis use and prenatal cannabis use in the past month. So I stratified these analyses by trimester. Also, as hypothesized, there's an inverse relationship between perceived risk of cannabis use and cannabis use in the past month during pregnancy. So for those in the first trimester, among women who perceive no risk of cannabis use, the odds of prenatal cannabis use were 5 times higher relative to women who perceive slight to great risk of prenatal cannabis use. In the third trimester, the magnitude of this association is even greater. Amongst women who perceive no risk of cannabis use, the odds of prenatal cannabis use were 14 times higher than those who perceived any risk of cannabis use. I did not expect to see this. I expected the magnitude of this association to be greater earlier in pregnancy. So I did not find evidence to support this hypothesis. So what does this all mean? Among all pregnant women, perceived risk of cannabis use is a significant correlate of prenatal cannabis use, particularly in the third trimester. With this information, we might be able to tailor treatment and screening efforts to potentially better help those women who are at greater risk. Among pregnant cannabis users, cannabis use was greatest in the first and second trimester when perceived risk was highest. This is very problematic because we don't understand why. That is not only contrary to my hypothesis, it's contrary to intuition, it's contrary to the state of science examining perceived risk in substance use in general. You typically don't use substances if you think the risk of use is great. What do we need to do moving forward? Certainly, we need longitudinal studies examining prenatal cannabis use and perceived risk in greater depth. As I mentioned, the data that I used for this study is a cross-sectional annual survey. So there's temporal ambiguity. We can't say that risk perceptions causes cannabis use. Additional research is needed for that. What we can do now is think about practice efforts. Certainly educate women on the risk associated with prenatal cannabis use, refer women to treatment when needed, and use non-punitive evidence-based interventions to treat and prevent prenatal cannabis use and substance use in general for that matter, as opposed to mandatory reporting or voluntary reporting, because it's important to note that New Jersey does not mandate healthcare professionals to report women for prenatal substance use, but there is voluntary reporting. And in my own practice, I don't report, but my colleagues do. They voluntarily report women for prenatal substance use because they think that they're helping. We have to work on provider education. Nevertheless, these points that I'm making about practice are probably already being done. I'm sure obstetricians, gynecologists, social workers, and other healthcare professionals are educating women on the risk associated with prenatal cannabis use and prenatal substance use in this matter. Treatment is not a new phenomenon. Substance use treatment, to include cannabis use treatment, has been around for since the beginning of time, I'm sure. In recent years, the percentage of women who report to drug treatment for prenatal cannabis use has increased in the United States. So women are seeking treatment either by referral or other means, right? And I'm sure even though some people, particularly in New Jersey, might voluntarily report women to the authorities or maintain these laws that criminalize or maintain these practices that criminalize prenatal substance use, I'm sure many providers do not. So this is not new news. So the bigger question is whether or not what we're already doing in practice is working. It doesn't seem to be, because prenatal cannabis use in this country is steadily increasing. I reported on this in a paper that I previously published in JAMA. And we see significant increases from 2002 to 2014. The prevalence of prenatal cannabis use increased. It increased from about 2.3% to 3.5% almost. And by 2016, this is the latest national data we have. Someone replicated my study, and the prevalence of prenatal cannabis use increased to nearly 5%. So despite our best practice efforts, prenatal cannabis use is increasing in this country, and women are using cannabis, even though they perceive great risk in use amongst those who use. So what do we do? Do we do more of the same? Certainly. In this case, we have to do more of the same. We have to educate, we have to treat, and we have to not criminalize prenatal substance use. But it brings me back to the original question. How can we help the most people at a time in terms of preventing prenatal substance use? In this case, prenatal cannabis use. We have to think about population level approaches, because treatment alone is not going to be enough. Health education alone is not going to be enough. And we have evidence to show that right now. We have to think about environmental strategies to prevention. We have to think about those macro level factors that influence substance use, in this case, prenatal cannabis use, and how we can intervene on those factors. And that's the work. That's the work that we're not often trained for, particularly if we're clinicians. And that is the work that even if we are trained for, there's a lot of pushback in that area. How do I convince the legislator to convince the state that there should be a moratorium in regards to cannabis dispensaries, for example? How can I convince the state, not particularly New Jersey, but any state in general, that although, or how can I convince localities that although cannabis use is legal at the state level, that it doesn't have to be permitted at the local level? That is not even language that we hear in terms of cannabis use legalization. I mentioned earlier in this presentation that 33 states have legalized cannabis for medical use and 11 states for recreational use. But the conversation doesn't often go further than that. Although states have legalized, localities still have autonomy to do whatever they think is best, oftentimes, for their jurisdiction. I talk about these macro level environmental strategies to prevention in the commentary that I recently published in JAMA Open. So just like at the beginning of this presentation, I leave you with this question. How can I intervene on risk perceptions of cannabis use and those macro level predictors of perceived risk in order to prevent prenatal cannabis use? I want to stop here and allow you time to ask me questions if you have any.
Qiana, thank you so much for this presentation. It's incredibly informative. And I guess the question that comes to my mind is, there was a national campaign around women and drinking during pregnancy. And so there is no support for any sort of initiative like this in terms of cannabis because the legalization is the push now instead. Maybe you can help clarify.
Right. This is a wonderful comment, a wonderful statement. Since the 70s in this country, we have promoted, there has been population level health education on the risk of prenatal alcohol use, specifically fetal alcohol spectrum disorder. So because this information was intended to get to lay people, there has been no population level health interventions to the same extent for any substance use during pregnancy, not for prenatal tobacco use, certainly not for prenatal cannabis use. And I don't think it's because legalization is the issue, because both tobacco and alcohol use are legal. It goes back to the fact that policy is not often based on evidence. Sometimes it's random. It's certainly good. I'm not saying that I certainly appreciate the population level health campaigns on the risk of prenatal alcohol use. There is no logical reason that there hasn't been similar campaigns for prenatal substance use in general, or specific substances, particularly those that are legal, cannabis, tobacco. It takes the work, it takes scientists, practitioners, advocating, lobbying to push forward policies and practices that will get this work done. And we often, because of many competing priorities, just don't have the time or the training. It's encouraged that we do this work, but oftentimes we're not supported in doing this work.
Hi, this is Jim from CHSR. Hi, Dr. Brown. I have one question. I mean, thinking about New Jersey, obviously, we just kind of, legalized cannabis at the state level through the legislature. What kind of impact do you think that's going to have on the perceptions that you examined about the harmful effects?
This is a good question. Because we've recently legalized cannabis in New Jersey, we have a unique opportunity to be on the side of prevention instead of on the side of treatment. There's evidence that suggests that prenatal cannabis use, the prevalence of prenatal cannabis use is higher in states that have legalized cannabis versus those that have not. I wouldn't hypothesize that trends in New Jersey would be any different. So the question is, what are we going to do about that in terms of these macro level health prevention strategies that I've alluded to? I have a couple of questions, and I'm free and available to consult with whoever is in power to make these decisions. One, policy, the wording of policy needs to be clear, right? And we can borrow. This is not just Qiana's thought of the day. Let's borrow from other substances. Public health had a big win in terms of prevention and packaging on cigarettes. We have 50% of the label to put a public health message or warning that we want to on cigarette packaging. Other tobacco, not so much. Different story for a different day. But that's a big win for tobacco in public health. What about labeling for cannabis products? What are we going to do when dispensaries begin to pop up in New Jersey? Are there going to be public health warnings? There should be. Who's regulating that? Who's thinking about that? Are there going to be public health warnings and advisories for pregnant women? There's research that suggests that cannabis use dispensaries are spewing invalid information to pregnant women. They tell pregnant women, not all of them, some of them, that cannabis use during pregnancy is safe, it treats morning sickness, and they have recommendations on what type of cannabis you can use to treat. They're not physicians. They're not going to school to give these type of recommendations. Who's regulating that? We can get in front of this in New Jersey. We can regulate cannabis dispensaries, not only by thinking about packaging, warnings on specific products, but warnings in the store in general, by ensuring that bud tenders or whatever the personnel are called that attends to the distribution of the cannabis, that they're not giving out health information that's contradictory to public health recommendations. We can borrow from alcohol outlet dispensaries in certain states and in certain well, not states as a whole, but in certain cities and jurisdictions, there's moratoriums. There can't be more than one alcohol outlet, a store that sells alcohol per 1,000 persons. Are we going to do something like that for cannabis? Nobody's mentioned it to me. So I think we can get ahead of this in New Jersey.
You know, it's interesting. Thank you, Qiana, that Evan brings up a question in the chat. I wasn't sure if you saw that about likelihood of getting a health promotion campaign on the risks of cannabis use during pregnancy at the state level.
Oh, I love that question. That's very likely. We have the NJX now at Rutgers, and I'm sure we can work with the Special Populations Corps because I know the person who directs it. I'm sure we can work with the NJX Community Engagement Corps to pull in these stakeholders, particularly the legislators, pull them into the table, let them know this is what we want. Not only that this is our demand, if you will, there's science to back up the suggestion for a population health campaign on the potential risk of prenatal cannabis use at the state level. Because the question that we're going to ask ourselves, that we have to ask ourselves, is do we want to be on the side of prevention or do we want to be on the side of treatment? And depending on what the legislator says to that, that's where they may or may not have my vote. So, and that's maybe the language we need to talk to them in, so something can be done. I see.
Following up on that, Qiana, because this is the time when the regulations are going to be written to implement the law.
Yes.
And there's a lot of money in this industry. So what would your recommendations be to the health department and the state house, to the people that are drafting the regulations on should, for example, the industry, the dispensaries or the other, they give different licenses for different roles in the chain, the producers, the distributors, should they be required to contribute to public information campaigns? Should the taxes from marijuana, should there be some set aside of that amount for public information? You know, you might recall that when they had this huge settlement with the tobacco industry, and the tobacco industry had to pay these huge amounts over to states for damages, and part of the thought was that some of that money would go to public information and smoking treatment, and most of it did not. So how would you, you know, because in this world where no good deed goes unpunished, you might have to write some letters to the legislators, to the health department and people, making some very concrete suggestions, you know, maybe with and maybe you could mention whether there are organizations in the state who are promoting this sort of thing as well.
Right. This is a good comment. And my short answer to this is if public funds are available and if an institution or organization, tobacco or cannabis outlet or otherwise, cannabis dispensary or otherwise, is going to impact the public, we always have to think about unintended consequences and mandates. Like one of my mentors said in the past about other things, we have to mandate equity. Public funds should certainly be used to promote public health. If your bottom line is has to increase at the expense of population health, that's dangerous, and that should never take priority. I'm certainly make your money. This is industry. This is, you know, open competition. I'm for whatever profit is going to be made, but never at the sacrifice of public health.
Yeah, you know, Andrea mentioned and I was thinking of the same person actually, Jeff Brown, that Jeff Brown would be one of the people who would be, somebody to bring all this information to bring this pressure to, and of course there are others. This is sort of like in Watergate, where they said to follow the money. So the money is going to be coming in to this giant new industry. All these new entrepreneurs are licking their chops, and the laws have to be written in such a way to govern where some of that money goes. Andrea, did you have any other comments about sort of how this process is going to take place and how it can be influenced?
Hi there.
Andrea made the posting.
I'm not a researcher. Dr. Brown, thank you for this. I'm just going to tell you, I'm a staff person here at RWJMS, but I'm interested in this field. And it's just that I've followed the history of how things have progressed over the last year. And again, you may want to look at the Cannabis Commission, look at the latest law in effect, and go dig a little deeper to see where that public education piece is. I am not familiar enough with it, but would be happy to talk to you more, and we could do some digging just to look in. And again, not from a research perspective, but my guess is that there is some sort of prevention language or some way in the law to address concerns. However, I do not know enough. I know little to be dangerous, and that's it.
I would love to work with you to figure this out, because and Francine, I see your hand, and I want you to speak next. We cannot approach public health, and in this case, unintended consequences associated with cannabis use legalization, to include potential increases in prenatal cannabis use. We can't approach this haphazardly, like the prevention efforts are buried down somewhere and we're going to check the box. And I'm not saying that's what you're saying, Andrea, but I'm saying that that's potentially what it is going to be. Because from a business perspective, they don't randomly expect to make money or just hope that it's going to work. There's a detailed business plan. We have to have a detailed public health plan to promote health equity, protect groups that might be at increased risk for cannabis use when cannabis use is contraindicated, like during preconception, pregnancy, and lactation. It has to be detailed and it has to be mandated.
Before we go to Francine, would you add school-age children to that?
Yes, certainly. So the a recent U.S. Surgeon General's advisory from our previous Surgeon General was released, and it discussed the risk of cannabis use, not only to pregnant women and women during lactation, but also to youth. So certainly, I'm talking about all groups when cannabis use may be contraindicated. Youth included, preconception, pregnancy, lactation, those periods of the reproductive time of reproductive period are included in any other scenario where cannabis use is contraindicated. These points, these unattended, if there's policy, this is the point I'm trying to make. If there's policy, fill in the blank with what the policy is for. Unintended consequences have to be considered and addressed in the forefront at the beginning of the creation of that policy. It can't be an afterthought, because if it is an afterthought, people go about implementing it with that same mentality. It's an afterthought, and we have to do it because the box has to be checked for whoever's monitoring the checks on the boxes.
Let's go to Francine.
Hello, thank you very much for that very informative talk. I'm an associate professor in the Department of Obstetrics, Gynecology, and Reproductive Sciences at Robert Wood Johnson Medical School, as well as the vice chair for the District 3 of the American College of Obstetricians and Gynecologists. And as an OBGYN, I'm very concerned about this. And I am very much in favor of a campaign for education, because I just think there's too many people out there that don't understand the risks. And if they understood the risks, they wouldn't be using it during pregnancy. And I think these ideas that some of the taxes or, money from some of these funds needs to go for educational causes. And when you look at things like alcohol, you can't walk into a restaurant that serves alcohol or a bar without seeing a sign, no pregnant woman drinks alone. And I think, there has to be very, big, print literature in any of these dispensaries that, people will get the message, as well as a more active, campaign to go. And if there's people here that, want to get more involved and work on the campaign, I am glad to support you and work with you, because I think it's very important.
Thank you, Francine. And I'm one of those people that want to be more involved and work on the campaign. My colleagues and I recently published a commentary in JAMA Open outlining some of the exact strategies that you mentioned, borrowing from prenatal alcohol use prevention and prenatal tobacco use prevention.
Can anybody address, Evan, do you want to ask your question, and maybe we can sort of, Qiana can tie in the alcohol issue with this, Evan?
Hi, so one thing I was wondering was where you had mentioned that there were those previous campaigns for fetal alcohol syndrome. I was trying to figure out, where did the money for those campaigns come from?
Well, the CDC, the Centers for Disease Control and Prevention, has sponsored several of those campaigns. So these are federal funds that promote health education. That's a good use of federal funds. In short, there may have been other money and other campaigns, I'm sure there were, but I don't know the details of the funding sources for those. But the CDC has sponsored many of the public health campaigns on the risk of on the risk of alcohol use during pregnancy, and that's a good thing.
Thanks.
You're welcome.
Qiana, part of what I'm thinking about is we're having this conversation is the way that people view cannabis use, and maybe that's not as a disease, but maybe that's as a moral failure. I mean, is that part of the conversation we should be having about how people who with substance use disorder have been viewed and stigmatized?
That's the conversation that we have every day of our lives. Addiction scientists, this slows progress. Stigma. Why are we still in that space that we're stigmatizing anything, yet alone substance use? Instead of treating it, instead of preventing it, particularly prenatal substance use. It's not only considered by some a moral failure, but you're a bad mother, you're a bad parent. And we have practices that uphold this stigma, such as mandatory and voluntary reporting. We don't think about the downstream. Social workers should think about this, if not anyone else. We don't think about the downstream effects of mandatory reporting. What about the foster care system that's already overloaded? When we're separating children from mothers as opposed to treating when needed and promoting family reunification or family preservation for that matter.
Qiana, when you think about this problem from the patient-centered point of view, this is something that Francine might want to comment on as well. The inference is that a nausea of pregnancy is playing a role and might contribute to the higher use in the first trimester. Of course, yes. There's also the possibility of women women unknowingly using cannabis during the first trimester. But the issue of nausea of pregnancy and the fact that we don't have too many drugs that are other strategies that are recommended in that situation. What are the ways that we could provide safer ways for women to manage that problem?
Right. So part of, and there's research to support this, part of the reason why cannabis use is so high in the first trimester, or particularly the first trimester, but it's also higher in the second trimester compared to the third. But part of the reason the prevalence of prenatal cannabis use is so high in the first trimester is because of pregnancy-related nausea and vomiting or morning sickness. So women who experience morning sickness often experience it in the first trimester. There's a small proportion of women that may experience morning sickness throughout pregnancy, but the majority experience in the first trimester. And those who experience morning sickness compared to those who do not have a significantly higher odds of prenatal cannabis use. Reasons that women state, particularly in qualitative studies, as to why they're using cannabis use, as to why they're using cannabis during pregnancy, is that they believe it's safe, they believe it's natural, and I'm assuming natural compared to something that's prescribed, a prescription medicine, and that they don't understand the science. In the sociology literature, there's this concept of public understanding of the science. And there is a gap in that understanding, in that translation in many areas, to include understanding the risk of prenatal substance use for many providers and certainly for women who may be using.
I think Francine has a comment on this.
Yes.
Yes, I just wanted to say there's certainly a lot of alternatives that are used for nausea and vomiting now. And years ago, we didn't have a lot of options. And after the thalidomide scare of the 60s, a lot of people were reluctant to use medications. But there are things that are out there and tested and work. And I think some patients, as you said, use things that they think are natural. And some people think natural is better. But we have to get out the idea that natural is better, because there are things that, are, chemical or pharmaceutical that have been shown to work. And, one of the medications that's available as a prescription, but you can kind of even make it up yourself, is a combination of vitamin B6 and the antihistamine that's found in some of the Unisom preparations that works for a lot of people. I'm not saying it gets rid of everybody's nausea and vomiting in the first trimester, but it does give a lot of relief. And there's also other anti-nausea medications like Zofran and Reglan that we use that weren't specifically designed in pregnancy, but have a lot of experience and a lot of data use in pregnancy that say they're safe. So I think if we could get the message out there that if people call their doctors, we'll get you something better, that would be very, important. I mean, I just had a call from a patient last week who called my nurse and told my nurse her marijuana wasn't working to get rid of her nausea. And, we were never even aware that she was, using it, because she hadn't even made it in, for her first visit yet. So, we got to get this message out to the public, because even though we can talk to all our patients when we see them, there's frequently a gap of 2 to 3 months from the time somebody conceives till they have their first visit. And they need, these important facts before they even see their doctor.
That's awesome.
I want to add to that. In this scenario, and I agree that patients should follow up with their physicians on alternatives that's safer to use or safe to use compared to cannabis use, because there's no known safe level of prenatal cannabis use. So we're going to be clear about that at this point. But also, I want to just follow up on Francine's point to call out the fact that her patient called and disclosed cannabis use. I mentioned earlier, what about all of the women who don't, because they fear that they're going to be reported? We can't treat or prevent what we don't know about. And if women are using cannabis to prevent nausea, and potentially other substance use that they won't disclose to their physician because of fear of being reported. That's a problem that we're going to have to address.
You also touched on something else that I think is very important in how we understand public health messaging, which is the ideology that is so prevalent that something that is natural is automatically safer than something that is made in the lab.
Right.
And now, of course, this story is getting complicated because now it's not just sort of natural marijuana anymore that we're dealing with. It's all the various extracts from marijuana that people are saying, because they can imagine the process whereby it came from the hemp plant. Then they say, well, obviously it's safe. Whereas the antihistamine, it's some strange plant that they don't understand. And so finding a way to counter these ideas about naturalness, and this goes throughout the supplement industry, which is enormous and largely unregulated. And as long as people can think, well, it comes from a plant. Well, lots of poisons come from plants.
That's true.
So one final question, since this is the special populations. Since our objective is to find ways to encourage research on the special populations, what has to be done? What are the opportunities for increasing research? Like, what are the kind of survey data that we need? For example, with the PRAMs and with the survey, how do we monitor what the potential adverse consequences are of these policy changes in states like New Jersey as they happen?
Right. We certainly have good surveys that are publicly available that will help us to continue to monitor trends in prenatal cannabis use and associated consequences, such as the NISDU, the data that I used in this study, as well as the PRAMS, the Pregnancy Risk Assessment Monitoring System survey. The goal of that survey is to monitor maternal and child health, particularly maternal health trends across states in the US. But these surveys are cross-sectional. What we need is well-controlled, longitudinal, population-based studies that can assess causation. We need to know those causal predictors of prenatal cannabis use, both individual and macro level, and we need to be able to intervene on them. That requires money, and this line of research is going to have to be priority to the people who are making the funding decisions.
What a wonderful way to wrap this up. And Georgette has a request to close us out.
And Qiana, thank you once again so much. And thank you everyone for attending. We're going to launch a quick poll, so if you could help out with our research efforts. And Qiana, thank you again so much.
You're welcome.
And this will be available, the program will be available on the YouTube website at the beginning of May. So thank you all so much.
Thank you. Thank you for having me.